beginning with the esophagus. Here's a cross section through the esophagus. Okay, you can see the lumen of the esophagus over here, and of course you can see the different layers of the wall of the esophagus. Look at the wall of the esophagus. The first layer we see is the mucosa. Remember, the mucosa consists of 3 layers. Someone give me the 3 layers. The mucosa consists of 1, 2, 3. First layer, right there.
Epithelium.
That's epithelium. Lamina propria is next. And then you got the muscularis mucosa. So this is really important for you to know. I'm going to use this term often. Mucosa, epithelium, lamina propria, and then the muscularis mucosa. And below that, we have the next major layer, which is below the mucosa. Submucosa. And the next layer is going to be muscularis externa, also known as the muscularis propria. Muscularis externa, propria. I think the propria is an older term. It's still used. And then the outermost layer, the serosa. Okay, so you want to know this by heart. I'm going to refer to the mucosa and submucosa in a question. You should know what I'm referring to, so you don't get lost. Okay, so that's a section through the esophagus. There's the lumen. You can see the different layers of the esophageal wall. The first of which is going to be the mucosa, consisting of an epithelium. The epithelium of the esophagus consists of a stratified squamous epithelium. Tough epithelium. It's got to tolerate the trauma of a food bolus passing down the esophageal tube. You can see the next layer is the lamina propria, and then you got the muscularis mucosa right there. Within the mucosa, you occasionally will see these aggregates of lymphocytes and macrophages. That is referred to as the malt tissue, the mucosal associated lymphoid tissue. It's in the mucosa, so it's called malt tissue. Okay. That is part of the normal physiologic inflammation you will find out the GI tract. GI tract is exposed to bacteria, some of which are symbions, some of which are pathogens. You need a defense against those organisms. You can't wait to launch a defense when you're invaded by pathologic organisms, or you can't even wait on the symbionts. You always have to monitor. You're always trying to invade the GI wall, so you have to keep them in check. That is the job of this physiologic inflammation, consisting of and including the malt tissue, the mucosal associated lymphoid tissue. The bowel is normally physiologically inflamed. Then you got the submucosa. There's the submucosa right there. Submucosa has lots of glands. They're referred to as submucosal glands. The purpose of those submucosal glands is to produce secretions that coat the interior of the esophageal lumen. Essentially, it is kind of a mucoid material that lubricates the esophageal lumen and just allows for a relatively frictionless passage of a food bolus right down to the stomach. Outside of that, we have the muscularis externa. It's also known as the propria. The muscularis externa consists of 2 muscle layers. There is an inner circular layer, in which the fibers are oriented like this. And then there's an outer longitudinal layer. These 2 layers structurally reinforce each other. And of course out here we have the serosa, which is the outer protective layer. A few things to know about that muscularis propria, that muscularis externa. Throughout the length of the esophagus, the composition of that externa will change. The proximal 1/3 of the esophagus, the externa, consists of muscle cells. skeletal muscle cells, rhabdomyocytes. The distal 2/3 of the externum is composed of smooth muscle cells. That's important. Skeletal muscle is under somatic control, and therefore, you can initiate a swallow voluntarily. Starts, but once it starts, the propagation of the swallow, consisting of a peristaltic wave, continues to propagate autonomically under the control of the smooth muscle and the autonomic nervous system. Any questions on this?
You said the epithelium of the esophagus is just stratified, or is it stratified?
Squamous.
Stratified squamous. You can actually see how thick it is. Okay, you'll also notice that the mucosa of the esophagus has this very convoluted architecture. Again, that convoluted architecture allows for esophageal distensions. When you do swallow a big bolus of food, the esophagus can distend without tearing that epithelium. All right, in our discussion of various pathologies, we're going to be referring to the upper and lower esophageal sphincters. Upper esophageal sphincter, not such a major problem. We don't really spend a whole lot of time on that, but the lower esophageal sphincter is the site of a lot of different pathologies. So we want to take a look at that again. We're looking at a section through the esophagogastric junction. This is the place where the esophagus, of course, merges into the stomach. We have a histologic section here stained with H&E. Above here, you can see the lumen of the esophagus. You can see the esophageal wall here, at least part of it. And down below, as we travel through the esophagus, you can see a point where the stratified squamous epithelium of the esophagus abruptly transfers into the secretory epithelium of the stomach. This is the stomach down here. The interface between the esophagus and the stomach is referred to as the esophagogastric junction. Some people refer to it as the gastroesophageal junction, whatever you prefer. Radiographically, if we were inspecting this junction with a barium-enhanced radiographic image of the upper GI tract, this esophagogastric junction would appear as a lucent zigzagging line, and as a result, alternatively, the esophagogastric junction is referred to as the Z-line. Z-line. That's more of a radiographic term. And it simply is a descriptive reference to the appearance of the esophagogastric junction as it would appear on a contrast-enhanced radiograph. Okay. Right at this esophagogastric junction is the site of the lower esophageal sphincter. Let's take a look at the architecture of the bowel wall, the GI wall at this site. Looking at the esophagus, we can see we have the stratified squamous epithelium here. We have this next layer, this is what? That's the lamina propria, and this thin layer of smooth muscle.
Muscular mucosa.
Muscular mucosa, and this? Submucosa, and this?
Muscular propria.
This is actually the inner circular layer of the muscular propria external. Alright, everything looks good here, architecture looks good here. We go down, we see there's an abrupt change in the epithelium, changing from stratified squamous epithelium to secretory epithelium. This is the stomach. And again, we have the different components of the stomach. We have the epithelium here, which consists of complex glands and gastric pits. In here, we have the lamina propria mixed up, and we have the musculus mucosa here, and then the submucosa is here. Now, if we take a look in this area, you'll notice that there is nothing anatomically distinct about this area that would allow you to recognize a sphincter. Doesn't seem to be anything that's different about this area that would correlate with a sphincter. And yet there is a sphincter that operates in this area. because you cannot identify the sphincter in anatomy, but yet there is a sphincter functioning here, we call a sphincter a functional sphincter, as opposed to an identifiable sphincter, which would be called an anatomic sphincter. Okay. There's nothing anatomically distinct about the muscle in this area that comprises the sphincter, and therefore we call it a functional sphincter. So the LAS is a functional sphincter, not an anatomic sphincter. The purpose of the LAS is to clamp down the distal esophagus, to prevent any gastric contents in the stomach from refluxing up the esophageal tube. Sometimes, especially when people get older, over the age of 40, the lower esophageal sphincter loses sphincter tone. It becomes incompetent. And the resting tone is so loose that the gastric contents is allowed to reflux up the esophageal tube through the loose sphincter, and it starts damaging the distal esophagus here. And it specifically starts to damage the stratified squamous epithelium, which can tolerate trauma but cannot tolerate acid bombardment. And as a result, the epithelium gets damaged and is eventually replaced with a metaplastic type of epithelium we'll talk about later. This condition is referred to as GERD, or gastroesophageal reflux disease. And while GERD itself can be a nuisance to the individual and cause a lot of retrosternal discomfort and colicky pain, it does have some other serious implications. Long-standing gastroesophageal reflux disease can lead to a condition called Barrett's esophagus, which is the immediate precursor of a nasty little thing called adenocarcinoma of the esophagus. Even though the reflux disease is a nuisance in and of itself, it does have some very serious long-term complications that are possible. Any questions here? Okay, let's take a look at the intrinsic nervous system of the GI tract. We spoke of this in physiology. The GI tract is its own little nervous system. In fact, very often, it is a nervous system that's described separately from the central nervous system and the peripheral nervous system. Some authors recognize it as an entirely different nervous system. It's called just the GI nervous system. Specifically, the nervous system that we're referring to is that of the myenteric plexus. Myenteric plexus is an integrated neural network that you find throughout the GI tract. The myenteric plexus is responsible for peristaltic action of the GI tract. It's also responsible for coordinating peristaltic action with the relaxation of sphincters and the increase of sphincter tone in various sphincter muscles. And let's have a look at it here. And we're seeing a depiction of the different layers of the GI tract. Again, you can see we have here the lumen. We've got the different submucosal layers and mucosal layers. And out here you can see we've got the muscularis propria. Muscularis propria, again, consists of two layers. There's an inner circular layer. There's an outer longitudinal layer. This muscularis propria, this muscularis externa, is innervated by a plexus called the myenteric plexus. It's the intrinsic nervous system of the GI tract. It coordinates all peristaltic action with sphincter relaxation and sphincter contraction. Something happens to this myenteric plexus. The GI tract in that area becomes aperistolic, and the sphincters in the area increase their resting tone. And so when the myenteric plexus is damaged, the sphincters clamp down, and there's no peristaltic action whatsoever. There is an alternative name to the myenteric plexus. Anybody remember what it is? Orban's plexus. Orban's plexus. I don't know what term they would use on your boards, but it would be very useful to know both. Okay, any questions on this? Let's take a look at the stomach. Okay, typical depiction of the stomach. We said this before in physiology. When someone represents a anatomic depiction of the stomach is always depicted as being composed of a single cavity. Anatomically, that's accurate, but we know functionally the stomach is actually compartmentalized into two separate chambers. And so in essence, even though we have one anatomic stomach, functionally we have two stomachs. Okay? Let's take a look at this. Couple of things we want to remind you of. So we have a depiction here of the stomach. There's the distal esophagus leading into the proximal-most portion of the stomach. That's called the cardia. Down here we have the main body of the stomach. It's called the body of the stomach, or the corpus of the stomach. And distally here we have the pylorus. Sometimes it's called the antrum of the stomach. Sometimes it's called the pylorus of the stomach. Sometimes it's called the antral pylorus of the stomach, or the pyloric antrum of the stomach. Okay? These are different parts of the stomach, and they are lined by different types of epithelial cells. Let's take a look at the different components of the stomach. So we have food coming in through the distal esophagus. There is a sphincter here in operation. This is where the LAS would be located. Normally it's closed and won't let any of the gastric contents reflux up the esophageal tube, resulting in damage. Instead, it normally is clamped down. However, when the esophagus is conducting a peristaltic wave distally, the myenteric plexus will coordinate that peristaltic action with relaxation of the LAS, so that when the food bolus is presented here, the LAS will relax and be passed into the proximal stomach. The first part of the stomach would be the cardia. The cardia is the most proximal portion of the stomach. It's lined by an epithelium that principally produces protective secretions like mucus. Above the cardia, we have another part of the stomach. It's called the fundus. Okay? The fundus is the most superior portion of the stomach. It's actually the part of the stomach that traps air. If you look at a chest radiograph and you see an air bubble under the left hemidiaphragm, that's typically air in the fundus of the stomach. The fundus of the stomach is primarily lined by an epithelium that produces protective secretions, but there are some acid-producing cells there. Over here, we've got the corpus, or body of the stomach. This is lined by a secretory epithelium that primarily produces acid and digestive enzymes. Within the epithelium of the corpus of the stomach, you will find parietal cells. Parietal cells principally produce things like hydrochloric acid and, of course, that glycoprotein we all know as intrinsic factor that chelates B12 and promotes its absorption later on in the GI tract. The epithelium also consists of chief cells, and the chief cells are principally responsible for producing digestive enzymes, such as pepsin. Pepsin is a family of proteases that will break down proteins. And also, the chief cells produce something called renin, not renin, renin. Remember I spoke about the pronunciation of renin and renin? This is why. Renin is a digestive enzyme that are principal cells, the chief cells of the corpus of the stomach. And it's spelled with two N's. Renin. Its primary function is to help curdle milk. It's more important in infants, growing organisms. But that's the enzyme renin. It's produced by the chief cells here in the corpus of the stomach. Distally, we have the pyloric antrum. The pyloric antrum, you recall, has a lot of endocrine function. Here's where you find the G cells. The cells that produce a hormone called gastrin. Gastrin is one of several hormones that controls acid production of parietal cells in the corpus of the stomach. The G cells are principally controlled by local pH. When pH starts to rise, they elaborate lots of gastrin to stimulate production of hydrochloric acid by the parietal cells. Parietal cells produce a lot of hydrochloric acid, reduce the pH. That will in turn inhibit the G cells from producing gastrin, completing a negative feedback. Questions on this? Why don't we take a break and we'll finish this up?